Okay, so we have the entire setup here.
I would like
the
to comment.
Yes, please, Dr.
The
Peterson.
last presentation, because I'm terribly excited about that concept of rehabilitation in one facility. And I even think with your smallness, that's the way to start. I mean, you're not going to serve 10,000 people overnight. And perhaps you should consider pilot projects, for example, with a drug or with a definition, the kind of thing that Leonard Jason's talking about, because it would really meet the needs of the people, and you could provide very useful information. You have all the infrastructure for endpoint monitoring, for example. If you wanted to use a questionnaire, or you wanted to use VO2 max, or you wanted to use pre and post SPECT scanning, or pre and post MRI, or whatever you wanted to do. So I think it's a marvelous. Our hang up in setting up a center like that is we can't afford it, and only the richest of patients can afford to go to a facility like that. So I'm thrilled for this country and for all of you. And if we can be of assistance, I'd offer that, because I think it's a tremendous asset. I was very impressed to hear this.
Thank you. Any more comments from the speakers right now? No? Okay. So again, we open the floor for questions. The lady in the middle. Again, please wait for the microphone so we can get this on tape, you know.
I have a question to Lena Nilsson. Like that?
Yes.
Yeah. Okay. I don't think this new center for ME rehabilitation will be an experimental center. I guess it's rehabilitation center. So if you are getting money, you need to have a plan what to do with these special patients, I would say, this kind of patients. Do you have some plan, not for other type of diseases that you usually use, but for this special group of people with ME? Do you have special plan for that, for their rehabilitation? Plan for rehabilitation, what you plan to do with them. Not just make experiments with different treatments.
We are not making experiments in rehabilitation. But what I've understood is that it's difficult for people to understand what individualized plans are. I mean, we do talk to our patients, and some need contact with the social worker to have help, support with the social insurance, and some need. Do you want to help me, because I have run out of English? Can I answer you in Swedish? Yeah. Alltså vi experimenterar inte, utan det är så här att vi har ett batteri av olika åtgärder som vi använder och som är evidensbaserade. Men om man ska prata om det så här i en föreläsning, så blir det ju alltså det blir svårt att vad vi skulle kunna göra är väl att göra fallbeskrivningar då, så att vi kan beskriva vad vi kan göra. Men är det någon av er som vill hjälpa till? Alltså vi kan, när det gäller till exempel vad gör arbetsterapeuten? Arbetsterapeuten kan titta på hur man använder sin energi i det man gör hemma. I aktiviteter som man gör hemma.
Omkring rehabilitering, eller så?
Kan
du ställa om fråga?
Ja, men programmet är... Ja. Nej, det intressanta är ju att många delar av den neurologiska, alltså vi räknar ju ME som också som en neurologisk sjukdom med liknande funktionsnedsättningar. Och många delar av det är lika. Och man kan använda likartade metoder. Eva, du får gärna fortsätta.
Ja, det sättet att tänka och förhållningssättet till att leva med någonting som man måste hantera på helt olika sätt beroende vilken människa du är. Att vi har ett exakt program, att nu kommer det en person som är så här, då gör vi så här. Allting är individuellt. Det måste vi göra eftersom att vi vet att det är också en väldigt heterogen grupp. Så att ett program som är precis, nu gör vi så här. Det är så fyrkantigt, om jag uppfattar det rätt, är det inte. Men vi har ju nu är Ulla på väg. Men vi har ju en gemensam kunskapsgrund att stå på, ett gemensamt förhållningssätt i att möta den här gruppen av patienter lika väl som vi möter andra personer med neurologiska skador och sjukdomar. Är det ett svar?
Nej.
Okay.
Hej, jag kan försöka också gärna på svenska om det är okej. Nej, alltså vår lilla erfarenhet av ME-patienten är inte så lång än. Liknar väldigt mycket, skulle jag säga, andra kroniska neurologiska sjukdomar som ME också delar det att de kanske inte syns. Det finns liksom ingen uppenbar funktion som liksom alla behöver hjälp med. Det är faktiskt så. Utan alltihopa måste basera sig på en individuell kartläggning av just den här människans situation, behov, symptom, önskemål. Och utifrån det, i den mån det här teamet då, som ändå har en ganska vid möjlighet att kunna hjälpa på olika sätt med en fysioterapeut, arbetsterapeut, kurator, psykolog som även har kognitiv kunskap, alltså att kunna testa kognitivt, så försöker man sy ett program som passar just den här personen. Och ett program, att liksom ha ett fyrkantigt program som att lägga på som en matris eller det tror inte vi på. Och man måste också få som patient själv vara med och skapa det här, därför att annars så gör man det inte. Man måste vara motiverad, man måste känna behovet, man måste också göra jobbet tillsammans med teamet. Så att ett program som passar alla, nej, det finns inte.
Och sen, om du frågar efter specifika behandlingsmetoder så kan man väl säga att fysioterapeuten kanske använder sig av yoga, kroppskännedomsträning. Arbetsterapeuten använder sig av att analysera hur man arbetar i aktiviteter och vad som kan underlätta, vad det finns för knep och strategier. Och även arbetsterapeuten och psykologen tittar på kognitiva svårigheter. Vad finns det för inre strategier man kan använda? Yttre hjälpmedel, förskrivning av hjälpmedel, hembesök, bostadsanpassning, möten med arbetsgivare och försäkringskassa, intyg där inte någon annan skriver intygen och neuropsykologiska utredningar om det behövs och så vidare.
Tryck på knappen. Okay, perhaps we should take the next.
Yeah, we'll take the next question over here.
Yes, thank you. I'm Professor Marko Partinen from Helsinki, from Helsingfors. I ask it in English. So I think that nobody has bed-bound or house-bound ME from the beginning of their disease, so that everybody starts with some kind of an inflammatory or infectious origin after a viral infection or something like that. So now we know from many other auto-inflammatory or autoimmune diseases that, and by the way, this is something that is it really an auto-inflammatory or autoimmune? We really don't know. But if you take juvenile diabetes type 1, you know, it starts in the childhood and then the beta cells are gone. In narcolepsy, we know that about 70% of the hypocretin cells have to be destroyed, and then they have full-blown type 1 narcolepsy. Celiac disease, another example. There are a lot of examples. And for example, in narcolepsy, we know that if we treat them with either intravenous gamma globulin or with rituximab, it should be given within the first 3 months of the onset, from onset. So very soon after onset. And then it may help if it helps. But if we give Evic or rituximab for a narcoleptic, after 1 or 2 years, it doesn't work anymore. So now when we go to ME CFS, I think that one thing that in the medical community we should think that if somebody starts to have chronic fatigue after an infection, we should act fast. If I go to your wife, if I remember right, so that when she started to have the symptoms, doctors should have reacted quickly. Okay, it doesn't go away. Could it be something like this? And then consider perhaps an immunomodulatory treatment or whatever. And we don't know the effect because that has. So this is something also for the diagnostic criteria. Same with narcolepsy, where we used to have 3 months of fatigue. And here we need 6 months of fatigue. And 6 months of fatigue is much too long time. I think that when it starts, you should act pretty soon, as Dr. Peterson was recalling to children for 3 months. But even 3 months may be too long. So my question now is to our US guests, that do you know that could there be really a time limit, and so that if we give an immunomodulatory treatment, let's say after 3 or 5 years from onset, could it be that it is too late, and should we perhaps try to start some trials, multi-center trials, trying to give the treatment earlier?
Well, I totally agree with you that when I see a case of acute post-infectious fatigue now, I'm always very quick to treat. But that's taken me years of experience to learn that that's the right way to do it. And I have a much better response. And what I generally do is I use intravenous gamma globulin and an antiviral at the same time. And it seems to be much more effective. I'll defer to Dr. Horning about if it's too late, once they're sick 5, 10, 20 years, something like that.
Yeah. Well, I think that at least based upon our findings of a difference in the immune profiles, that early on with the immune activation, perhaps you want to do something to dampen down the immune response, whereas later on, perhaps because there appears to be an immune exhaustion, at least at least in our studies, find that the long-term patients have a drop in their cytokine production and so forth, that perhaps doing something at that later point may be something different than you would do earlier on, and that something might be along the lines of Ampligen or Anakira, something that would actually boost up the cytokines that are at low levels. But again, we need to know that how many people, and we need to replicate this in other cohorts too.
Can I ask another question? Considering that CFS or some forms of the disease that we are talking, so some subtypes, maybe more like chronic inflammatory diseases. So do you have experience, or what is the current experience of use of some kind of anti-inflammatory treatment, long-term anti-inflammatory treatment?
Long-term, I don't know, but I certainly have experience with people who have taken high-dose steroid therapy, for example, and initially had an excellent response. Their mind clears up, their pain goes away, but I'm concerned about the long-term consequences of that kind of immunosuppressive therapy.
Can I still ask some? No, this is something which is an future.
Perhaps a last short question from you.
No, some future therapies in autoimmune diseases. One of them is fecus transplantation, so that you take your mother's fecus and you inject into in the gut. And the other one is helmintic therapy. Do you have any experience or ideas? Could they have some ideas?
I don't have direct experiences. I don't see patients anymore, but follow the research in that, in that area. Not so much for ME, but for other disorders that are presumed to have a subset that may be autoimmune, like autism, for example. So, and so there have been some case reports where there appears to be an improvement with the helminthic therapy, and it's hard to know what the basis of that is. We had actually thought about doing a study to see whether the helminths actually alter the bacterial flora, in addition to the known IgE production and so forth that you would see with a helminth type of therapy. There's a report out of Australia, I think, in terms of using fecal transplantation and so forth for ME with some long-term follow-up. I guess they call it bacteria therapy. It sounds a lot nicer, but it's this, that same idea. We're really, I think we have to use caution. We're really in our infancy, in terms of the research on that area. But the animal models are very promising in terms of altering even, MS type of models, experimental autoimmune encephalomyelitis being able to be altered through a microbiome replacement therapy. But we really don't know enough about how genetics contributes to that, and whether, how long you would need to treat, or whether you can induce some of this by long-term probiotic therapy as well. It's just not enough research, I think, to, yet to be certain that it's safe or would be effective. Any thoughts?
I have had people try stem cell transplants, which are not available in the U.S., but they are in South America particularly, and they have not reported a beneficial effect. And the N is getting up there now that enough to say I wouldn't recommend that to people. The fecal transplant, it's very popular right now. Americans are into that, so we'll see. It would be nice to do scientific research, I think.
Thank you. More questions from the audience. Man in the back there. Mike is coming.
Thank you. Do you hear? I have a question about the energy metabolism. It's not clear to me whether this fatigue means that you don't produce enough ATP, or whether your mitochondria is not really working. Because if you haven't physical exercise and get very tired, you need to rest for days and days and days, and a normal person is okay the next day. Is that because of overproduction of lactic acid, so that you're actually poisoned more or less, or acidified? Or is it because you cannot produce simply enough ATP? Because most of the people here who have studied any biochemistry knows that from one molecule of glucose you get a hell of a lot more ATP if you use the Krebs cycle as compared to if you use just the cellular cytoplasmic mechanism, which gives you only 2 ATP. Do you have any comment about this, please? And a second question, when I have the microphone in my hands, do you know whether histamine plays a role in this, whether people describe that they get a lot of sneezing and things like this, and whether that can be referred to as a disturbance of the regulatory pathways with respect to this, immune modulation? Thank you.
We're currently doing 2 types of, investigations using our the data sets that we have. One is focused on comorbidities with allergic disorders, and people who are chronically taking either sedating and non-sedating antihistamines in association with those comorbidities. They're not necessarily taking it specifically for any ME-related disorder. But we also are just beginning to analyze data, metabolomics data, which includes all of the amino acids. And so we're very keen to look for disturbances there, at least in the subset, and to see also whether it relates to the reported allergic comorbidities as well as medications that people may be taking, so histamine, and also even certain amino acids like alanine, which are commonly increased in the setting of lactic acidosis. So we'll see. I think it's important to follow because, mitochondrial defects, can occur as a post-infectious, type of phenomenon. And, I think that's worthy also of pursuing directly mitochondrial DNA studies as well.
No more comments on that? No? Okay, I think there was another question in that corner.
I'm very interested in the pharmacological treatment, and I would like to ask, in the clinic in US, which are the most used drugs for a normal ME patients? Which drugs do you use most? Do you use tryptophan, for example, or other drugs that you give to a lot of the patients?
Well, there's certain caveats that we always use. For example, always the lowest dose necessary to get the effect, because the patients are very sensitive to higher doses and have all the side effects. The primer that I referred to goes over the experience across many clinicians about what they find most useful. For example, for restless leg syndrome or for pain or for sleep. I don't think there's any particular magic to it. There's not like one drug that I would recommend for sleep. I tried various ones. There's and I start, one of the premises I use is I often ask the patient, which is the one symptom you would like me to deal with, but don't choose fatigue. So choose brain fog or sleep or pain or one of those where the agents are beneficial, very beneficial. And in the same line, so goes it with people who say, well, I would just like to be able to do something every day, which is where rehabilitation comes into play. So, but I don't think there's one drug that stands out in my mind that every patient should be on.
And if the patient would choose brain fog to be treated?
If you choose brain fog?
Yes.
Oh, yes. Well, if you choose brain fog, that generally is, that's the category of patient that I do more studies on, like functional brain scans and MRIs, et cetera, to try to get more information so I can make a better decision about what to use. For example, if they have increased intracranial pressure, then I might use something like Diamox. If they have evidence of inflammation in the CNS, I might use an anti-inflammatory. If I'm simply treating brainstem dysfunction, which shows up on a PET scan, I might use one of the brainstem stimulants like Nuvigil or Provigil, or even sometimes the amphetamine-based drugs, which can be very beneficial for the brain fog. If it's based on orthostatic intolerance and hypotension, as was mentioned earlier, then I go very vigorously after orthostatic hypotension and try to increase cerebral blood flow, which can be demonstrated pre and post treatment as well.
Okay. Another question down there. Speak up and keep it to your chin here, please.
Oh, okay. Do you see any connection between ME and narcolepsy? Because it seems like both diseases started after this Pandemrix vaccination campaign. I mean, not all, just some of the cases, ME started after vaccination, but that's the two kind of diseases you can find, they have maybe something in common. Do you have any comment on that?
Well, actually, we have a paper coming out soon in vaccine that, based upon a Norwegian cohort, that suggests otherwise, that at least in that population, that less likely with immunization than with actual pandemic flu infection, so H1N1 pandemic infection. There, so I think that there's, there's mixed, data on that side. But, I think that the presentation, it may be quite different. The post-infectious type of scenario is very common in ME, whereas I'm not quite certain that is as prominent as the early prelude with narcolepsy. But there are probably others in the audience who have much more experience with that presentation for narcolepsy as opposed to ME.
And just a follow-up question.
Very short now,
yeah,
please.
Very short. You're talking about treatment from brain fog. I have tried 2 patients with the modiodal, it's called modafinil substance, and it seems like some patients have quite a big benefit. I had one patient, she was sleeping for 16, 18 hours a day, and now she sleeps 8 or 9 hours, and well, she feels much better. But I guess maybe that's a coincidence. You have any comment on that?
Short answers. Last second. No comment on that from the stage here? Any expertise in the audience? No? Okay. So I think we have to break there. So, okay. Thank you again for good questions. Thank you for excellent presentations. Well, I think that Henrik perhaps will urge you to give all of the speakers a warm hand. So I will just say thank you for the attention, and thank you for giving me this honorful assignment, I must say. Thank you, and good luck with all the important work, I must say. Thank you.
And thank you, Michel, for being a very good moderator. So the ME CFS Patient Association would just like to thank you for being here, attending this conference, and making this happen together with us. So thank you a lot, and hope to see you next year again. Thank you.